We are live now.
So welcome everyone to this webinar today. And we have a galaxy of speakers and a very important subject to cover actually. The, uh, the subject is ocular infections, and we are basically, it's a case files on infection management. I think infection management is always, sorry, infection management is always a very important topic, and we have great talks and a galaxy of speakers with us. Dr. Ashok Nanda, who's the founder and director of the Car Vision Eye Hospital from Bhubaneswar. He will be talking to us on antibiotic prophylaxis in cataract surgery. Dr. Lionel Raj, who's from Dr. Agarwal's Eye Hospital, Tirunelveli, a surgeon par excellence. And apart from that, he's, I think, won numerous international and national awards and has presented at many international forums. He's going to be talking about viral keratitis. Dr. Rajesh Sinha, who is the treasurer of the AIOS and professor at RP Center for Ophthalmic Sciences, again has extensively published and has won numerous awards. He's going to be talking about bacterial keratitis. My very good friend, Dr. Chintan Malhotra, who's from PGI Chandigarh and additional professor in cornea, cataract, and refractive surgery services. Again, uh, uh, published very extensively and presented a lot. And she's going to be talking about, I wouldn't say a new entity, but I would say something that we tend to miss, and that is microsporidial keratoconjunctivitis. Then Dr. Madhu Daraju, cornea and refractive surgeon again, director Sri Kiran Institute of Ophthalmologist from Kakinada, Andhra Pradesh, who's going to be talking about fungal keratitis, and he's been involved with a lot of landmark studies which are done on fungal keratitis, especially the multicentric studies and international multicentric trials. To his credit, he also has a lot of innovations, and notable amongst them is the slit lamp eye bank specular. For there's a slit lamp modification by which you can do specular microscopy in eyes, donor corneas for eye banking. Then Dr. Bhupesh Bagga, again, who needs no introduction, he's a consultant at cornea and anterior segment in LV Prasad Eye Institute, Hyderabad. He's going to be talking about acanthamoeba keratitis, and he's done a lot of work on infections and did a great conference on the in the Bugbusters very recently. So thank you very much for being there. And I would request Dr. Ashok Nanda to give his first talk, which is going to be prophylaxis of infection in cataract surgery. I think you have to unmute yourself. Dr. Ashok Nanda, you have to unmute yourself.
Yeah, now am I audible? Sorry.
Yes, yes, yes.
Thank you for the opportunity to speak my views on antibiotic prophylaxis in cataract surgery. We all know that the elderly population is increasing globally, and so also the number of cataract surgeries increasing worldwide. And the cataract surgical rates in India is one of the highest across the globe. In spite of progress in technology, we have shifted from couching to femto laser, but still endophthalmitis is a nightmare to most of us. The overall surgical endophthalmitis varies from 0.01% to 12% in various ophthalmic procedures. In spite of increase in the number of cataract surgery, fortunately, the endophthalmitis rates are decreasing. And in 19th century, it was about 10% of surgeries getting infected. Mid 20th, it is 1%, and now it is about 0.05% to 0.3% in various studies. The credit to decrease in endophthalmitis has been attributed to better sterilization and aseptic techniques, better instrumentation, better surgical techniques, and prophylactic use of antibiotics and antiseptics. We have to keep in mind about the following things to decrease endophthalmitis: improper preoperative preparation, unhygienic periorbital factors, wound construction, and intraoperative complications. These are factors. In addition to that, systemic immunosuppressants or immunosuppressive conditions can also play a role. Bacteria from the ocular flora are the major cause of infection. The source is from the ocular flora, mostly the lead and the conjunctival flora, and sometimes from the nasolacrimal duct. Unlike Western population, where 70% of all organisms are gram negative, in India, gram positive, in India, gram negative and fungus do play a significant role. So hence, when we choose antibiotic, we have to think of both gram positive and gram negative cover. Amongst the organisms, the most frequently identified organism is Streptococcus epidermidis and Staph aureus. In addition to that, gram negative and methicillin resistant organisms are also very common. Methicillin resistant organisms are more common in elderly age group and in diabetics, and it happens to the extent of about 20 to 30% of all organisms in the conjunctiva and in the leads. In addition to the source from conjunctiva, leads, and lacrimal sac, contaminated instruments, irrigating fluids, contaminated gloves, and airborne contaminants has to be also looked into. In spite of the best surgical procedures, the contamination can occur in best of centers, and therefore the role of antibiotic prophylaxis is significant. So we have to take prevention both at preoperative, intraoperative, and postoperative sectors. And preoperatively, it is believed that betadine 10% scrub and 5% topical providone iodine eye drops can help in a major way to decrease endophthalmitis. Pre and postoperative topical antibiotics, tight wound closure and preventing capsular rupture, and intracameral antibiotics are the mainstay to avoid endophthalmitis. So in spite of reducing rates of endophthalmitis, still prophylaxis with antibiotics is a must. What are the options? We have preoperative oral and topical antibiotics, intraoperative injections through irrigating solutions, subconjunctival or intracameral, perioperative and postoperative topical medication are the means of administering. Antibiotics which are commonly used are from the cephalosporin group cefazolin, cefuroxime, vancomycin, aminoglycosides, and from the fluoroquinolone groups. The second and third generations are not used anymore. It is the fourth generation, moxi and catafloxacin, which are used. Now, having said that use of antibiotics is indicated, we have certain controversies that still come to our mind when you go through the literature that are published. American Society of Cataract and Refractive Surgery, ASCRS survey in 2014 said that 85% of their doctors prefer antibiotics, out of which 48% start 3 days before, 32% start 1 day prior, and 20% start on the day of surgery. Now, studies by endophthalmic study group, ESCRS have, and some other publications have already proved that prior antibiotics a day or 3 days before do not have any significant advantage. 1 hour before surgery, if any fourth generation antibiotics are used, for fourth generation fluoroquinolones used, that is even better than using preoperatively. Dr. Vasavada et al. Have compared the doses regimen of moxifloxacin 4 times daily 1 day before versus 2 hours before the surgery, and they have found that the MIC concentration that is achieved in the aqueous humor is much better when it is used 2 hours before the surgery. We know that inoculum load required for endophthalmitis is much less if it is exposed to vitreous compared to anterior chamber. So therefore, the importance of a retained posterior capsule plays a very important role. And we have seen whether we use or do not use antibiotic with a retained capsule, the incidence of endophthalmitis is always less than 0.01%. And when it is without the capsule, in spite of using antibiotics, the incidence can go high as 0.5%. Antibiotics in the irrigating solution was proven to be an effective method where the vancomycin in the irrigating solutions had a concentration more than MIC for 6 hours after surgery. However, with use of intracameral antibiotics, the number of people who were using irrigating solution antibiotic has drastically decreased. Now, intracameral antibiotics, cefuroxime, has been tried in large multicentric studies. 1 milligram in zero point 0.1 ml is the dose, and it has been found to be effective, better than subcutaneous injections. It has been found not only to be effective, the safety has also been established in various studies. And one important study is from LV Prasad, where they found, though the decrease in endophthalmitis was seen, it was not significant. However, the effect of cephalosporin on retinal thickness and endothelial cell density was not there. So it is pretty safe also. After 2006, there has been an increased proponent of use of moxifloxacin intracamerally, given in the dose of zero point 0.1 milligram in 0.1 ml, and there was no significant adverse effects to the corneal endothelium and retina, and it has been a good drug for intracameral use. However, vancomycin has been tried in many centers. The only problem is that it is not very effective against gram negative, and there are instances, reports of cystoid macular edema. The question that arises is certain anecdotal studies where they have said that endophthalmitis incidence is not altered by giving any intracameral antibiotic. So there are still people who believe that intracameral antibiotic has no extra benefit. Subconjugal injection of antibiotic was prevalent before. Lot of high cohort studies have already proven that subconjugal injection was important, but however, after intracameral injection was prevalent, no more these are given in the eyes. Oral post-operative topical antibiotics, again, there are various reports which go in favor and some go against it. A large 72,000 patient cohort was published by Ryan et al., and it was found that the incidence of endophthalmitis was significantly reduced when antibiotics were given, moxifloxacin was given post-operatively topically. Whereas other studies published by ESCRS endophthalmitis study group and some other groups have not found any significant advantage of giving post-operative topical antibiotics. Systemic antibiotics, of course, has not been used for long now. A study published in Ophthalmology in 1999, where 3 lakhs eyes were evaluated, and oral antibiotics was not found to be having any extra benefit over topical. Now question is, we are definitely going to use both because of the AIOS guidelines telling us that we should be using antibiotics topically, and of course, medical legal point of view, we should be using antibiotics. How to choose? It depends on antibiotic bioavailability, and it depends on the antibiotic resistance of your community. We all know that fourth generation antibiotics, both gatifloxacin and moxifloxacin being better available in both conjunctiva, in the cornea, and also in the anterior chamber. The bioavailability is better. The only question is their retention in the conjunctiva is usually less than 4 to 5 hours. However, the dose schedule is about 3 to 4 times a day. So the only drug which can stay longer, more than 6 hours, is probably gatifloxacin 0.5%. Therefore, it can be used in 2 to 3 times or even 4 times a day dose as a prophylactic drug. The other point that we are concerned about is the rise in resistance. This is a significant, this plays a significant role in both developing and underdeveloped countries. In addition to that, the number of new antibiotics being developed in the last few decades have been really less. We all are aware about this bug, super bug, which was, which hit the highlight in 2018, where Times of India said that resistance to the last antibiotic has surfaced in India. So judicious use of the drugs is very essential. We have to select an anti-infective based on the susceptibility study, which are large sample. We have to select it based on local demographic studies and the susceptibility pattern, and of course the pharmacodynamics and pharmacokinetics of the drug. So, American Journal of Ophthalmology 2002 publication said that amongst all the fluoroquinolones, the MIC of gatifloxacin and moxifloxacin are the lowest for gram positive and gram negative organisms. Others are developing resistance. The first publication about resistance in fourth generation fluoroquinolones were from AIMS in 2007. Also, David Chang also reported about increasing resistance of moxi and gatifloxacin. Similar publications came from various other countries also, not only from India. There are variety of publications from India, especially both from north and south. There is a publication on Pseudomonas resistance where from 2007, it was 19%. It increased to 52% in 2009. Similarly, from Kanpur also 57% showed resistance to moxifloxacin. RP Center AIM study showed that in 2007, gram-positive organisms were almost 95 to 96% susceptible to the fourth generation fluoroquinolones, and gram-negative 75% to 85%. However, subsequent studies have shown the increased resistance to both GATI and MOXI. Even one study from Bhubaneswar L.V. Prasad is so very disheartening that post-operative sensitivity was only 50% to gatifloxacin and 25% to moxifloxacin, published in Indian Journal of Medical Research 2014. I can give a lot of examples where it has been seen that the sensitivity of both GATI and moxifloxacin is dwindling, and we have to the resistance is increasing for both gram positive and gram negative. So we have to actually be cautious about what type of antibiotic we give in prophylaxis, and it will also mostly depend on a proper periocular hygiene, preoperative preparation, and a well-conducted surgery to help us in fighting against the bacteria. Thank you.
Thank you, Dr. Nanda, for a very nice and lucid presentation on this very important issue, which we keep discussing in most of the forum. And I guess we still have our fingers crossed that what exactly is the correct thing to do. One thing is very sure that in the end, what you are telling that, we are having emergence of resistance. And that is very sure that it is basically perhaps because of the fact that we start giving, for cataract surgery, it is for prophylaxis. So we start giving the highest generation of antibiotics in the post-op period. And that perhaps may be a reason why this can lead to resistance to these antibiotics. So what is your pre-operative and post-operative regime in your cases? You're mute.
I follow pre-operatively 1 hour before the surgery, 4 times daily. Mostly it is moxifloxacin because I gave intracameral moxifloxacin in all cases, and it is continued post-operatively after the surgery for 7 days. That is my routine practice. Recently, we have done a few, at least about 200 cases where I have not given intracameral and only put on gatifloxacin, and the results have been equally good. Only pre and post-operative gatifloxacin, no intracameral.
Mm-hmm. Actually, perhaps the pre-op prophylaxis that we take in the form of use of povidone iodine, that is perhaps the biggest safety measure that we take in order to prevent endophthalmitis. And that's why the occurrence of endophthalmitis is so less that, in a small number, it will be difficult to exactly pinpoint whether intracameral antibiotic has a definite role or not. But maybe if we go for a very large series, then in a small percentage of cases, it does show some difference. However, once again, it is the preoperative role of povidone iodine that has been emphasized the most, which is most effective in preventing endophthalmitis. Any opinion on that? Dr.
I
Namta,
think I quite agree. I quite agree, Rajesh, that it is povidone iodine that really does the trick. And about intracameral moxifloxacin that some people also want to give, what they give as a prophylactic agent. It did show in the retrospective studies from Arvind that it helps. But if you see, there are no very large scale prospective randomized controlled studies, and you need a really huge sample size to say whether it really works or it doesn't work. And I think there is one study which is going on a sample size of 75,000 patients from ASCRS. So I think that will surely give the answer. We are also doing a study, and Rajesh is also a part of it, where from RP Center we are doing it, a randomized controlled study of 15,000 patients. So 7,500 are getting moxifloxacin, 7,500 are not getting moxifloxacin. So I think we do need answers, although retrospective data also helps us to know. But povidone iodine is, I think, is the savior for everything, whether it is COVID or it is infection. It seems to be the savior for everything.
Um, Sir, povidone
So I
iodine,
think
yeah,
yes,
if
yes,
I have
Sam.
a question, povidone iodine, I too agree that is the biggest protection against post-operative infections. Rajesh, sir, how is your approach on prevention of gram-negative group of organisms? Because all these quinolones, the fourth generation quinolones are so gram negative still they are
Yeah.
one of the biggest challenge, especially when if it is a cluster. Uh,
yeah. See, actually, the thing is that once again, I would say that, whatever we do in a cataract surgery, we do for prophylaxis. And for prophylaxis, we have to, we cannot have an approach different for gram positive, negative. So I guess um, for prophylaxis, I mean, whatever we are following, the role of povidone iodine preoperatively will take care of everything. Once we have an endophthalmitis in a case, then we will have a slightly different approach in gram negative and gram positive. But in order to prevent infection, any infection in a cataract surgery, I guess we have to follow, and most of us, we are following the same regime role of povidone iodine in the eye, which will prevent everything. I mean, as Dr. Namta said, whether it's COVID or it's mm,
Moreover,
negative.
actually, when you talk about a cluster endophthalmitis, the sources are usually not, from the ocular
Yeah,
surface. Ocular
mostly,
surface,
yeah.
yeah, ocular surface have mostly the gram positives. So gram negatives come from outside. Outside. That is very important. The pre-operative procedures have to be looked into. The question is about the legal aspect. Can we escape a legal claw if we have only used povidone iodine and not used antibiotic and the patient goes into endophthalmitis?
I guess this for the same reason we all have started using intracameral antibiotics, because to tell you frankly, even without use of intracameral antibiotics, my personal experience and opinion was that there's no need for that. And over the last, I think maybe 1 year or so, I've started using it because of the legal aspect only. Because then, because there are documents which state that there is a role of intracameral antibiotics. So perhaps because of the legal aspect, it is more important to be safe. And that is why we have to take all the steps that are mentioned, that can be documented in a court of law, that this does have a role, but it was not done in this particular case. So perhaps that is the reason what you have, we have hit the bullseye actually. That is perhaps the reason why we have to take all the measures in order to prevent infection in these
So
cases.
are you using it in all cases now?
Yes, yes.
Okay.
Yes. I mean, to tell you frankly, I mean, there was the difference of opinion, but my opinion was I was doing it for last almost, so 96, so many years have gone, and I hardly had any, endophthalmitis, because of the reasons that we used to, do cleaning of the eyes and everything preoperatively, we done in cleaning, and then intraoperative, but first we instill betadine, leave it for some time. So So all these precautions were taken. So it never happened actually, but because of the legal reason, because of keeping legal point in mind, I thought that we should use it in and document it. Actually, we should document it also that it has been done, because in a court of law it can be pointed out that this is something which is there in international literature, but it was not followed.
What about putting post-operative betadine iodine immediately after the surgery? There are surgeons who put a drop of povidone iodine 0.5% post-op. Do you advocate that?
I don't, because post-operatively I just put one drop of antibiotic, and that is it. I don't advocate that.
I also don't feel it's safe, because we know that there is a wound leak. Whatever we do, how much of sealing we do, there is a negative suction effect which comes within 2 to 3 hours, and the betadine going into the antechamber probably is not a good idea.
And I guess preoperatively, if we have used betadine for sufficient time, then I mean, there's no need for, we have used all the instruments, sterile instrument. And whenever there's a cluster endophthalmitis, it's the most common cause that has been implicated is the fluid.
Yes.
So I mean, the fluid has been used. So even if you put betadine over the surface, whatever has been used and it is inside the eye, it will not take care of that. So post-op, immediate post-op at the end of the surgery, I don't think there is a definite rationale for use of povidone iodine.
So there was one other point I wanted to make about the resistance which is developing. People tend to give antibiotics post-operatively for even a month, and they will taper it, with the steroid, they start tapering the antibiotic also. So I think that's a practice which strongly needs to be discouraged. Antibiotics 4 times a day for a week or so are enough, and you don't need to carry it on beyond that for a month or so.
Absolutely. And that is perhaps the reason why I personally don't use a combination drug.
Yes, absolutely.
Post-op period, in post-cataract surgery, I don't use a combination. I use antibiotic and steroid separate. So that way you can taper the steroid, but you can
Without tapering that.
after 2 weeks, I normally do. And some people do it for 10 days, some people use it for 21 days. So it's variable. Okay, so we move on to the next speaker, and we have an excellent speaker again, Professor Lionel Raj, who will be talking about viral keratitis. So let's hear from him the intricacies and the details of viral keratitis.
Good morning, everyone. I generously thank AIOS, Professor Namrata Sharma ma'am, Dr. Rajesh. I thank all the panelists, the viewers, and Allergan for arranging this meeting, even though it's on a Sunday. So even though my topic was mentioned as viral keratitis, viral infection of the ocular surface can be from adenovirus to herpes simplex, herpes zoster, or even the novel coronavirus. But I will confine myself to herpes simplex, as I'm also involved in one of the in developing vaccine for herpes simplex. So herpes simplex virus is associated with a variety of ocular diseases, including epithelial, stromal, and endothelial keratitis. HSV can cause stromal opacification and is believed to be the leading cause of infectious blindness all over the world. The global incidence is roughly 1.5 million, including 40,000 new cases of severe monocular visual impairment each year. As we know, it's a DNA virus. It's a large virus, just like a zoster, belonging to herpes virus family, and has a double-stranded DNA genome covered by icosahedral protein capsid and glycoproteins, which are studded on the surface. And special mention is to glycoprotein D and B, because they are very much important in development of subunit vaccines. The WHO fact sheet displayed in 2017, January, it has estimated 3.7 billion people under the age of 50 years. That 67% of population had HSV1 infection globally, and 11% of population had HSV2, that is between 15 and 49, the sexually active period. In Indian scenario, viral keratitis, HSV keratitis has shown a steep rise. However, there is a paucity of data. And for every 200 patients visiting an ophthalmic practitioner, one is known to have a viral keratitis of HSV etiology. 60% are between age of 21 to 40, and 27% are reported between 41 to 80 years, and 70% and more are from the rural population. HSV infection is ubiquitous in human. Nearly all of the autopsy reports over 60 years, the autopsy of the trigeminal ganglion had shown HSV genome sequences when studied. Most primary exposure occurs early in life, and 1/3 of the population suffer from recurrent infection of the cornea. As I said, the primary infection generally occurs early in life. This is the nomenclature and classification of herpes infection of the eye, of the cornea. It involves all the layers, epithelium. It can produce a dendritic ulcer or a coalesced dendrite, which can result in geographic epithelial ulcer. And stroma, it can cause stromal keratitis with epithelial ulceration or without epithelial ulceration. And endothelium, it is known to cause endotheliitis, which may or may not be associated with trabeculitis and iridocyclitis. So according to HEDS, which is one of the landmark studies in herpes viral disease of eye, 47% had accounted for epithelial and 16% for stromal keratitis. When we think about recurrences, it is 46% stromal keratitis are known to recur. This is a classical epithelial keratitis of herpes simplex origin with a terminal bulb, a dendrite, and a geographic ulcer. The endotheliitis is thought to be of hypersensitivity reaction to viral antigen, and a central zone of stromal edema, often associated with epithelial edema, keratic precipitates, folds in the Descemet's membrane, a ring of stromal haze, IOP may be elevated, reduced corneal sensation. This is suggestive of deciform keratitis or endotheliitis of herpes simplex origin. Necrotizing stromal keratitis, as we know, most often it is associated with vascularization, and it directly points out to active viral replication within the stroma, and often associated with stromal necrosis and melting, and leads to progressive scarring, vascularization, and lipid depositions. Failure of reepithelialization as a result of poor corneal sensation can result in non-healing epithelial defect and a neurotrophic ulceration of the cornea. Iris defects seen over here, and this is most often associated with herpes simplex iridocyclitis. When we think about how this infection produces a latency and reinfections, the antigrade transport of HSV viruses happen either from the eye or from around the mouth, generally in HSV1, and they go for a latency in the trigeminal ganglion. Even there are studies which has quoted that HSV from elsewhere region, from different dermatomes, can enter into trigeminal ganglion, and with the favorable circumstances, they proliferate and produce a retrograde antigrade movement to the cornea, and they cause recurrences. So as I said, after primary infection, the virus is carried to the sensory ganglion, and that is the reason for latency and recurrences. The rates of recurrences, 60% gave history of recurrences, while only 40% and less had only one attack. 57.5% had recurrences within a period of 2 years, and 44% had involvement of the other eye, which generally is not seen in my practice. Generally, it is most often a monocular disease. Recurrent corneal infection by herpes simplex virus is a common cause of blindness in otherwise healthy individuals. For an average follow-up of 6.9 years, a recurrence of 0.6 episode per year, half an episode per year was observed. And in most of the cases, a deciform keratitis in 84% of cases recurred as deciform keratitis. Epithelial keratitis recurred as epithelial keratitis in 72% and endotheliitis in 75%. This graph shows in the first 1 or 2 years, the recurrence rate is very high. And the number of recurrences, say for example, if there is a second recurrence, then the incidence is more high. Or in other words, if a patient is a frequent relapser, or if he has frequent recurrences, then the risk of developing recurrences in the future years is very high. Diagnostics, we have direct view morphology, immunomorphology, immunological virology, viral culture, serology, and molecular virology. Most often what we do is antibody assays. We use ELISA or CLIA, Western blot, and PCR. ELISA is a good sensitive and specific test for detection of antibodies. So is the Western blot. PCR has sequencing of the viral genome. It's 60% sensitive and 100% specific. For clinical users and most of the researchers, especially for corneal endothelial changes and vascularization, confocal microscopy plays a vital role also. Reduction of corneal sensation is one of the key parameters associated with HSV keratitis. So anesthesiometry plays a role. With all this background about HSV, since the meeting is also about case files in infections, I would wish to show some of the interesting case files from our clinic. So this is a 6-year-old boy, a primary herpes lesion. Most often this is missed. Either it occurs around the eye or around the lips, and most often it is missed. This is a classical epithelial herpes simplex infection, which has occurred in 56-year-old man. And he had 6 recurrent episodes in 2 years. He's a diabetic, a very close associate of our hospital also. And every time he had associated rise in intraocular pressures following, it's a keratouveitis type. This is a 48-year-old female, post-herpetic deciform keratitis. She had recurrent herpes deciform keratitis and had scarring. Endothelial dysfunction, I'm sorry, it's not scarring. Endothelial dysfunction, who underwent EK and who is on steroids and antivirals, and who could have good vision subsequently. This is a case. About this case I'll discuss later also. Neurotrophism can lead to perforations, and this is an impending perforation. A grafted eye for herpes simplex keratitis, and a recurrence seen, which is treated and healed, a new recurrence seen. And these are patients who will require antivirals, oral antivirals for long term. This is a case with the ghost vessels in the cornea with the intact epithelium. So 29-year-old male presenting as recurrent interstitial keratitis, where the epithelium is intact. A differential diagnosis of crystalline keratopathy, pencil-like, a fine crystal-like deposits in a case of recurrent HSV stromal keratitis. So this is a close differential diagnosis for infectious crystalline keratopathy of strep viridans. So this is the gentleman whom I discussed, recurrent keratouveitis. And here I could show on the second picture a long-term antiviral therapy with acyclovir toxicities. A case with deep stromal vascularization, already existing scar, a recurring lesion treated, which enlarged and subsequently which has healed. So these are people who will require a long-term oral antiviral therapy. Sclerokeratitis, recurring sclerokeratitis. You can see the opacities and a fresh lesion, fresh area in 18-year-old female. Congenital HSV keratitis, HSV1 and 2 can be acquired in utero. Of all the neonatal HSV, 4% is acquired during the uterine life, and 86% occurs at the time of birth, perinatal, and remaining 10% in the postnatal period. So this is an image taken from textbook, and this is how congenital HSV, genital HSV lesions appear on the skin. Neonatal HSV keratitis, though it is rare, it usually presents as bilateral disease 2 days to 2 weeks of age, invariably associated with keratitis. This is in one of our case, a neonatal herpes stromal keratitis, active ulceration. It has high morbidity because of whatever treatment we give, they tend to recur, and amblyopia as a parameter. So when we talk about HSV, there are few landmark trials, especially HDS 1 and 2, one in 1989 and 2 in 1992. So HDS 1 aimed in 3 important things. Does topical corticosteroid and herpes simplex stromal keratitis help along with the antivirals? It did help in most of the cases and reduced treatment failures. However, it did not affect the eventual visual outcome by 24 weeks, but it did help. Does oral acyclovir help in HSV stromal keratitis with concomitant topical steroids and antivirals? There were no apparent benefit. That was the result from HSV1. Oral acyclovir and herpes simplex iridocyclitis, yes, it had benefit, but still the strength was less in that particular study, but it had benefit in iridocyclitis. In HSV2, does an early treatment in epithelial lesions, early treatment with oral acyclovir, does it help? It did not help. And how about long-term prophylaxis by using a low-dose oral acyclovir? It definitely helped reducing any form of keratitis by 41% and reduced bad, severe form of vision-threatening keratitis by 50%. So that is one thing which really we need to have in our mind while treating HSV stromal diseases. Does any external factors like UV rays or corneal trauma or behavioral factors, did they have any influence? There were no statistically significant effects. In 2014, Michelle White came up with this treatment guideline, and I'll quick run through this. For an epithelial keratitis, a dendrite, a therapeutic dose of topical and oral antiviral agent. Oral antiviral in the strength of 400 milligram 3 to 5 times was advocated for a week to 10 days, in addition to topical agents. For a geographic ulcer, a therapeutic dose of topical plus full dose of oral antiviral, 800 milligram 5 times a day, was given for 2 to 3 weeks along with topical. Topical may be ganciclovir or acyclovir. In stromal keratitis with epithelial ulceration, a therapeutic dose of topical corticosteroids, I mean without ulceration, a high dose of topical corticosteroid plus prophylactic dose of 400 milligram twice daily of oral agent to be given. For a lesion with ulceration, the topical steroid strength was reduced, whereas full dose of oral antiviral was initiated. Endothelial keratitis, a therapeutic dose of corticosteroid plus therapeutic dose of oral antiviral, prednisolone 6 to 8 times. Most often it is hypersensitivity to viral antigens, so it has a role. Definitely steroid has a role. And acyclovir 400 milligram 3 to 5 times a day. And the recommended corticosteroids are fluoromethalone, prednisolone phosphate, prednisolone acetate, and difluprednate. We use prednisolone acetate in most of our cases. Special circumstances in HIV infected person, low dose acyclovir need to be continued. And potential indications for prophylaxis of long-term oral antiviral therapy in HSV keratitis, they define. One is multiple recurrences of any type of HSV keratitis, especially stromal keratitis. So multiple recurrences, recurrent inflammation with scarring, which involves or approaches the visual axis. More than one episode of HSV keratitis with ulceration, it's a strong stimulus. And post-keratoplasty, post-operatively in patients with history of HSV, especially cases like even cataract surgeries, we may have to continue. In patients with history of HSV during immunosuppressive treatment. So the recommended prophylaxis is acyclovir 400 milligram twice daily for a year. And there is no optimal duration which has been fully established, but at least 1 year, reduced recurrences for 2 years. Surgical management, these are the various surgical managements, but we generally go for lamellar surgeries or penetrating surgeries. HSV is one of the most important indication for repeat surgeries or regrafts after primary graft failure. Different authors establishing different incidences of regrafting. This is one of our case number 12, where after 5 years also, not very active graft host junction vascularization, and the graft is doing very well. But not all cases will be doing this way. So the recurrence rate of HSV keratitis in patients without oral antiviral prophylaxis was reported to be 32% by 4 months, 44% by 21 months, nearly 46% at 1 year, and 27 to 50% by 2 years. This is one of our case, a central inactive scar following HSV stromal keratitis. We did a lamellar keratoplasty, and the patient did not use oral acyclovir and did not turn up for follow-up during COVID times, and last month had presented this way. So long-term prophylactic treatment with antivirals is more important. And here may be lamellar keratoplasty or a penetrating graft, the risk is the same. That is what is being established by different studies. This is one another case following a lamellar surgery, and patient is a 26-year-old man, an army person who lived in Assam in the border, did not find oral acyclovir agent over there, and was sent again with such a bad recurrence, and after oral acyclovir he improved this way. So PKP, any keratoplasty in HSV keratitis, take-home messages are use of intensive post-operative topical steroids, oral acyclovir prophylaxis for 12 to 18 months, and a strict follow-up also is definitely required. Cataract surgeries and HSV. This is one of our cases where a mature cataract, inactive stromal herpes, and post-cataract surgery in a couple of months came up with high viral stromal reactivation. So general recommendation is, again, in any type of surgeries, including cataract surgeries, antiviral prophylaxis should be strongly considered and should not be stopped in the immediate post-operative period, especially if it is stromal keratitis. So this is our team of rational vaccines, and I'm fortunate to work with Dan Kerr, who has extensive research about working with mice and New Zealand white rabbits in HSV1 vaccine. Todd Margolis from WashU, and Greg Hollander. He's part of COVID vaccine development team of Oxford vaccine candidate also. So I'm really happy about it. And regarding vaccines for HSV, HSV is most common cause for infectious corneal blindness, but still no relevant clinical trials in evaluating impactness, in evaluating vaccines are available. Success of a vaccine against zoster gave an idea about the HSV vaccine development, and the use and necessity for effective HSV-1 vaccine is often overlooked because of availability of oral antiviral agents. And of course, latency and reactivation of stromal necrosis are the greatest challenges for vaccine. And presently, our candidates, we have cleared all the latency testing. And this is one of our candidates, O delta NLS ICPO for HSV1. HSV2 is the first which would come into clinical trials. We also work on super subunits of glycoprotein D and B. And recently we have acquired another VC2 candidate, which had cleared most of the preclinical stages of vaccine development. So with all these, I again thank AIOS and Allergan for having given the opportunity to present this morning on some of our case files on HSV keratitis and the developments in vaccine industry. Thank you, one and all.
Thank you, Dr. Lionel. It was a very nice, comprehensive talk on viral keratitis. There are a couple of issues that always come up regarding the recurrence and regarding the use of prophylaxis. What is your take on what should be the duration of prophylaxis for a recurrent case of viral keratitis and in grafts? I mean, one in non-grafts and one in grafts.
Got it, sir. So HEDS has given a clear guideline. Prophylaxis for 1 year definitely reduced the recurrence by 50% of severe form of keratitis. But still there are no consensus on how long should we carry on. As I mentioned, there was one of the studies where if we give a prophylactic dose of 400 milligram BD for a period of 1 year, for the next 1 year, you may still have a recurrence-free period. But again, all these cases are like some, as I shown, they don't show a recurrence, but 60% of candidates, they are likely to have recurrences. So as long as patient could tolerate, as long as the liver enzymes doesn't go high, I tend to carry on with the oral acyclovir 400 milligram twice a day. And if it is a grafted case, graft indication being recurrent stromal herpes, then at least for 2 or 3 years, I would continue.
Actually, even for grafts, I guess, that is what is becoming the consensus now, that as long as you can, and as long as the patient tolerates, and as long as the liver enzymes and the renal function, everything is fine. So as long as you can, because there was the earlier consensus that we should do it for 1 year, but
there's no definitive
1 year also, that's
point.
no more relevant. Yeah, absolutely agree. Another point I would like to just add here that sometimes we do get a recurrence of CMV endotheliitis. And many times when you treat the patient, if it's a case of a endotheliitis, and we are treating the patient with acyclovir and it's not effective, it's not working. We are treating with acyclovir and steroid and it's not working, then one should have this, some degree of suspicion in mind that CMV endotheliitis is also a possibility. And particularly after grafts, there's one study which has shown that, in their cases, 6% of which had the recurrence of keratitis, viral keratitis, was CMV keratitis. So that is also something that one should keep in mind. And if that is the case, then maybe if it's not resolving, it's a graft, and it mimics graft rejection also. So if it's not resolving by pulse steroid and by the use of all these, or if it's in any cornea wherein it's not resolving with steroid and acyclovir, one should investigate for CMV endotheliitis, and one can do a aqueous tap and do a PCR. and
Or a simple antibody also,
antibody also,
CLA or
yes,
ELISA
that
also give.
coefficient, the Wilmer coefficient, that works well. So that is something which one should keep in mind. I mean, that is what I wanted to convey message.
Got it, sir. Got it. Nice point also.
Okay, so we move on now, and the next after viral keratitis will be bacterial keratitis, and I'll be sharing my slides about bacterial keratitis and what should be the management strategies. Now, when you are managing a case of bacterial keratitis, the strategies depend upon the severity of the disease. So you have to assess the severity, you have to identify the organism, because it's the organism that you have to hit. And if you hit it correct, then your resolution will be there. So appropriate antimicrobials for eradicating the organism. And you shouldn't keep on using for very long, just like that, because there can be drug toxicity as well. And if needed, one has to go for surgical management at appropriate time. So assessing the severity helps a lot. Why? Because it is not just theory. It gives you an idea what should be your approach. There are various studies that have come up which have shown that you can use a single drug, fluoroquinolone, or you can use a combination drug of cephalosporins and aminoglycosides. There are a couple of studies which have shown comparable results, but there is a consensus among the corneal surgeons that if it's a mild ulcer, you will go for a single drug, fluoroquinolone, and if it's a moderate or severe ulcer, you will go for a combination. So this is something which is there, and that is why perhaps grading of corneal ulcer is very important. And also to tell the prognosis to the patient that, this is the situation, so this is going to happen, and we are trying our level best to get the resolution. Now, identifying the organism is the key, because you have to hit the organism by appropriate antibiotic. And identifying the organism, you can identify by getting some relevant history, like somebody who is giving a history of injury with a vegetative matter. You will start thinking in terms of fungal. If somebody gives a history of some surgery, you start thinking in those directions. So by history, by associated event, you will get to get some idea about the organism, by clinical examination, and of course by investigations like scraping and microorganism detection. Now, somebody who has undergone LASIK and has come to you with post-LASIK keratitis, literature is not just to read, but to help you to manage cases. And this is how it helps you. That it gives you an idea that, these are the common organisms that can present in post-LASIK keratitis. So you have to keep these in mind. You have to keep atypical mycobacterium. Normally, a patient who comes to us with a bacterial keratitis, something with a central infiltrate, etc., we start thinking in terms of staph only, first of all. But here, if a person comes to you immediately after LASIK, maybe a day or two, then it can be Pseudomonas or polymicrobial. We have reported such cases from RV Center. But if somebody comes a week later, 10 days later, the first thing that comes to mind is atypical mycobacterium. So you have to investigate for that. And this is the survey that was done long back, which states that atypical microorganism is quite commonly seen. Now, if somebody has undergone an intracorneal ring segment procedure, as you can see here, this is the infiltrate that is seen. And this is unfortunately intracorneal ring segment operated by me only. But, fortunately, the patient recovered completely. So if you have a case of a post-intact keratitis, you start searching that what can be the organism. And literature suggests that most often it is Staphylococcus. So the first thing that you will do is that you will remove the suture, send it for culture. You will start thinking in the lines, empirical treatment in the lines of Staphylococcus. So this is how you guide your management. Now, infection after CXL, you have all these organisms that have been reported in literature, and you have to think in all those directions. Post-keratoplasty keratitis, gram-positive cocci is the most common organism, and you have to start thinking in those lines, apart from the investigations, of course, that you will do. And subsequently, you will modify your management depending upon the response and depending upon the report of the culture sensitivity. infectious keratoplasty, crystalline keratopathy after laminar keratoplasty, or after even LASIK has been reported from our center. And you can have alpha hemolytic streptococcus or staph that can be the cause. Post-DSEC, this is an example of a post-DSEC keratitis wherein, or even post-anterior laminar keratoplasty keratitis. This is also called a sandwich infectious keratitis, or SIC, or interface infectious keratitis. Why? Because it starts from the donor tissue and then progresses in the interface, remains in the interface for some time, and then involves the host tissue. And the common organisms that have been reported are Candida, actinomyces, Mycobacterium, Klebsiella, and Staphylococcus. So you have to start thinking in those directions. And the most important thing that you have to do is that you have to look at the donor rim, because it's the donor tissue that is more often the culprit in causing this interface infectious keratitis following any laminar keratoplasty, whether it's anterior or a posterior. In immunocompromised, this is an immunocompromised individual having HIV, and he was on heart therapy, antiretroviral therapy, and we had a multiple case series of this, and we reported this. We found out that the common organisms were Staphylococcus and Acanthamoeba. Staphylococcus, somebody will immediately think, and of course polymicrobial was also seen in a few, because it's there in the ocular fauna, but Acanthamoeba one will not think. So these things you have to keep in mind when you are dealing with such patients. A case of bullous keratopathy, you have a reduced local immunity. So Staphylococcus, Streptococcus, these are the common organisms that can cause. Contact lens induced infection, if you get a ring infiltrate, something like this, you will start thinking in the lines of Pseudomonas or Acanthamoeba immediately. If it's a very short period, like the patient immediately progresses very fast, then it can be Pseudomonas. But if it's slowly progressing, then it can be Acanthamoeba with such kind of a ring infiltrate. But you can have other organisms as well, like Staphylococcus, Fusarium, and Cavillaria, and you have to think in those directions. Now, there are certain findings that give you diagnostic clues. Like if you have a localized round or oval ulceration with grayish white stromal infiltrate that have distinct borders, then you will get a gram. You are more in the gram positive cocci group, because the borders are distinct in gram positive cocci ulcers. But in a gram negative organism, the borders are not that distinct. There's surrounding edema, there's ill-defined borders. So that also gives you a clue that probably we are dealing with this, and that is how you start your empirical treatment. Then a case of pneumococcal ulcer, you get a serpiginous border, undermining advancing edge. If you have a Pseudomonas ulcer, of course, it will be a very devastating and fast. You will have yellowish green discharge, and you have infiltrate ring ulcer, and very fast it will melt and perforate. If you have a nocardia, you can have a cracked windshield appearance or a hyphae edge, etc. It simulates a little bit of fungal type picture. And then, of course, you have to do microbiological workup based on the scraping and culture sensitivity. You do staining, you make smear, you do PCR. And scraping is basically done with the help of either Kimura spatula or surgical blade number 15. That is the best. And you can send it for staining and for culture. There are various stains that are used. Gram stain is more often used. If you're suspecting in the form of, atypical mycobacteria or nocardia, etc., you will go for acid-fast stains. So that is how you get an idea what exactly you have to do. Bacterial cultures have to be done. Direct plating is always better. So you direct plating. And if you have, negative cultures, which can be seen in a sterile ulcer, or which can be seen because of inadequate sampling, or if somebody is on partial antibiotic treatment, then you have to stop antibiotic for 24 hours and then go ahead and do a scraping. And if repeat scrapings are not coming out to be positive, then you will have to do a corneal biopsy. As far as drug therapy is concerned, as I said, that it depends on the severity of ulcer. If it's a very small ulcer, you can go ahead and treat it with a monotherapy of newer generation fluoroquinolones. However, if it's a slightly moderate or severe ulcer, then in that case, my personal preference, and worldwide, people prefer combination therapy of fortified cephalosporin and aminoglycoside. Now, there are a couple of studies which have shown that, fluoroquinolones are comparable to combination drug, but this is the consensus that if it's a mild ulcer, very small ulcer, we can go ahead with a single drug therapy of fluoroquinolone. But if it's a moderate and severe ulcer, we have to give combination therapy. And sometimes we do have to give even higher concentration, and that is why, the newer drugs are coming up. If it's a post-LASIK keratitis, flap amputation is something that we all should, emphasize, and we all do it, because if the infiltrate is there in the interface, it's not going to disappear unless you do amputation of flap. Sometimes, in a couple of cases, what I've done in a couple of my case, wherein the infiltrate was slightly in the periphery, so I've done a partial amputation, and that also has worked. But if it's in the center, then you have to remove the flap completely, and then accordingly treat depending upon the organism. And amikacin is something, or near fluoroquinolones can also help. Now, post intracorneal ring segment keratitis, if you have, then you remove the suture first, send it for culture. And that gives you an idea that the case that I had shown, I had sent the suture for culture, and that clinched the diagnosis. But if it's just in the radial tunnel, then in that case you can do scraping there. You can do a intensive antibiotic therapy, and that will work. If it's involving in the tract, then in that case you may have to do excuse me, channel irrigation as well. And but if it's involving the base of the ring segment, which is ring segment lying over the infiltrate, and it is underneath the ring segment, then in that case you will have to remove the ring segment. Otherwise it will not heal up. And then remove the ring segment, and then do thorough channel irrigation with antibiotic. Sometimes it doesn't work, and or sometimes the patient comes to you a little late, and then you have to do a therapeutic graft in such a case. If it's a post-ALK or a anterior lamellar keratoplasty or DSEC keratitis or a DMEC keratitis, whatever it is, if it's an interface keratitis, you have to remove one part. Like in LASIK also, it's a sort of an interface keratitis, you do the flap amputation. Similarly, if it's an anterior lamellar keratoplasty has been done and you are having an interface keratitis, you have to remove that lenticule, and then only it will clear up. Otherwise, if you wait for a little period, you will have to do a therapeutic graft in that case. Or if it's a DSEC keratitis, then you have to remove the DSEC lenticule immediately on day one, so that you can send it for culture, and you can give intracameral antibiotics, and you can treat the patient intensively, and then only it will clear up. Otherwise, invariably, you will have to go for a therapeutic graft. Once there is a healing phase, you have to reduce the drug therapy. As far as the steroid is concerned, if it's a bacterial keratitis, as I'm talking, then after initial response to therapy, if there is a reduction in infiltrate, we can give steroid in order to reduce the inflammation. But of course, you have to rule out coexisting fungal infection, or if there is and if we do excessively for a long period, then sometimes it can result in stromal melting and recalcitrant microorganisms as well. Now, if there is a perforation or impending perforation, or if there is a scleral or limbal involvement, or if it's a virulent organism, we have to give systemic antibiotic. And as far as changing drug is concerned, if there is no response to the therapy that we have initiated, then we should change the drug depending upon the culture sensitivity report. But whatever be the culture sensitivity report, if there is a response to treatment, then we have to stick to that. If it's a progressive ulceration, which can be because of resistant strain, virulent organism, or inappropriate medication, or poor compliance, or intensive steroid use before the treatment, then in that case, you can have perforation. And if you have a very small perforation, like this is not a perforation, actually, it is an impending perforation, or just a desmet is visible. So you can just put a very small cyanoacrylate glue, put what we prefer, we use this small filter paper cut into small size, we put it, and then we put a bandage contact lens. It works very well. It doesn't allow it to perforate. It causes healing as well. But if it's a if it's a perforated also, then you can go ahead, inject air inside, and you can put sunacrylated glue. If it's a perforation like of this size, then the glue will not help. So in that case, you will have to do a small patch graft. And these patch grafts in the peripheral perforations, they are very useful, very effective. The patient does not have to do anything. I mean, the patient is visually rehabilitated also very well after that. He may have some astigmatism, but that can be tackled by RGP contact lens later if everything is fine, or even by glasses. So things work quite well, but if it's a central perforation or a large perforation, in that case, you have to do a therapeutic keratoplasty. So I'll just move fast due to paucity of time. And this is how you enter. You have to be really careful in entering the anterior chamber, inject viscoelastic, remove all the tissue that is necrotic, remove all the tissue that you can see that is having infiltrate. And once you have done that, you inject intracameral antibiotic also at the end of the surgery. And sometimes if you have even the minimum doubt about the edge, then you can even do stromal infiltration of antibiotic in that edge. So all these things you have to do in order to handle this perforated ulcer. And post-operatively also we have to give antibiotic therapy, definitely in a lower dose, so as to take care of the whatever residual infection that is there. So a case of bacterial keratitis, we have to go ahead with a stepwise approach for diagnosis and evaluation. The most important thing is to identify the organism, because we have to hit the organism and we have to hit it hard. We have to be aggressive in our early treatment. And if it is not working, then in that case, we may have to do a surgical management. So thank you very much for your patient listening. And I'll be happy to answer any question. Yeah.
Thank you, Professor Rajesh. Actually, there are many cases who come to us little late, and we are actually forced to start off with antibiotics fortified. My question is, if you are going to fortify an antibiotic, the patients being from rural area, they would prefer to take 2 or 3 bottles with them. So how long is the fortified antibiotic effective to be kept not in a refrigerated scenario?
It's the most difficult scenario that you're talking about, because we advocate fortified antibiotics to be used, prepare and use it within a week, for 1 week, not more than that. So if a patient cannot come for follow-up, then in any case, the patient, whatever he is taking the treatment, will invariably end up with a perforation. So that is what we have to emphasize. And perhaps in such patients, in rural patients who are not coming for follow-up, and if they can say that we can't because we're coming for a very distant place, and we cannot get admitted here also, in any case they have to go back. So such are cases which are useful. They are the candidates for the higher concentration of commercially available antibiotics. Like we have 1.5% levofloxacin that is available and showing reasonably good result. We have 0.5% gadifloxacin that also works well. So I personally would feel that instead of compromising on breaking down of the constituted antibiotics, I will prefer them on a higher concentration of the antibiotic that is available in the market.
My second question is,
meantime, sir, we generally in our center a reconstituted antibiotic, we don't use the shelf life. We tell it is 48 to 72 hours. More than that, we generally don't use. And in a given situation like what you mentioned, definitely I would insist on admitting the patient because
yeah. But if the patient is not getting admitted also, then in that case, what he is presenting the scenario,
yeah,
it's
actually
really a higher concentration
from
of
villages,
antibiotics.
they do not come prepared to get themselves admitted because the attendants do not want to stay. That will lose their livelihood, no? So
Yeah.
that is the scenario. Normally, it gets over in 48 to 72 hours if you are putting a half
Yeah.
an hourly or 1 hourly.
Yeah.
So we tend to ask them to come in 7 days, but sometimes it happens. My second question is, if you have a small ulcer and you said you prefer a monotherapy with a fluoroquinolone, would you prefer a 0.5% concentration of gadifloxacin versus a 0.3%?
I will prefer a 0.5%. I have a few of the few cases of even 1.5% of levofloxacin also monotherapy with small ulcers, and they have responded well. So, I mean, if somebody with small ulcer or somebody who cannot come for follow up, I will prefer 0.5% gadifloxacin, which is a good drug.
But even 0.3% ciprofloxacin is known to work better in small ulcers because it has
Yeah.
wider coverage on gram negatives as well.
Rajesh sir,
Yeah.
what is your take on the loading dose, sir? Like giving it every 5 minutes initially, and then when the patient is still there in the opinion, then taking it to 1 hourly later.
I think there are people who have done it, and I personally don't do like that. I usually prescribe half hourly initially for the first 48 to 72 hours. But yes, it can be done. Some people do it for every 5 minutes, for 30 minutes, and then start half hourly or 1 hourly. So that is also one option that one can do. And there, I mean, a couple of in a couple of presentations, people have presented that it has reasonably good results. So I think that is also one way of.
Thank you, sir. Thank you.
And we do also give half an hour or 1 hour. We don't load with every 5 minutes. But having worked with the SCUT study group also, I was a co-investigator there, and most of the bacterial keratitis, including Pseudomonas, after a couple of days of antimicrobial therapy, they responded well when there was an addition of steroid. Only for the pneumococcus, which was little, uh, uh, it could not be easily tracked. Pneumococcus was more deadly than Pseudomonas in that particular study.
Yes, sir.
Okay. I guess Dr. Nanda has to leave.
Yeah, I'm here for another 15 minutes, no issues.
Okay,
I'll
okay.
listening to
So
the next.
let's have Dr. Chintan now, who will be talking about microsporidia keratitis.
Thank you, sir.
Her presentation.
And I'll start sharing my screen.
Yeah, yeah.
At the outset, I'd like to thank AIOS Professor Namrata Sharma and Dr. Rajesh Sinha for this opportunity. And I'll be speaking about microsporidial keratoconjunctivitis. So as it is a webinar on case files, let me start with a case first. These are the pictures from a 35-year-old lady. So she was an IT professional and she complained of watering, redness and foreign body sensation in the left eye for the last 5 days. And a closer look showed that there was a follicular reaction on the inferior palpebral conjunctiva with a papillary reaction in the upper lid and lots of congestion of the ocular surface. And as we look at the cornea in a broad slit, we see there are lots of coarse lesions on the cornea, grayish-white lesions. And further staining with fluorescein shows them to be much more numerous than are seen clinically. And it appears as if each of these has been kind of stuck onto the cornea or painted onto the cornea. On retrospectively asking, she had gone on a vacation some 2 weeks ago and had gone swimming after that. And after a week or so, she developed those symptoms. Now, this is a classical picture which one would associate with a microsporidial keratoconjunctivitis. And the wet mount of the QH wet mount of the corneal scrapings and the calcofluorite showed these ovoid bodies, which are suggestive of the microsporidial spores. I'll be coming to this in detail later on. Another example, again, a very typical scenario. It's a 28-year-old farmer with a foreign body sensation and watering for 1 week and minor trauma while working in the fields. If we look at the diffuse picture, we often tend to miss the lesions which are seen only in the periphery, the two yellow arrows pointing to some grayish necrotic epithelium at the edges along with the conjunctival congestion. But you stain with fluorescein and lo behold, the whole of the cornea is studded with these pinpoint lesions. So this morphologically, this could be described as a coarse corneal epitheliopathy, which has a stuck-on appearance or a painted appearance. And this again is classic for microsporidial keratoconjunctivitis. However, we need to be aware that pre-treatment with steroids may lead to coalescence of these lesions, and a lot of our patients would be pre-treated with steroids if they are coming late in the course of the disease, and sometimes then the diagnosis may not be evident. It's important also to realize that there could be various differential diagnoses for a coarse multifocal keratoconjunctivitis. The most important amongst them would be the adenoviral keratoconjunctivitis. Here, your history and your associated findings help to differentiate it from microsporidia. You would have associated pharyngitis, fever, preauricular lymphadenopathy, though not in all cases. Then herpetic keratoconjunctivitis can also present with this epithelial lesions, where some of them probably would be dendritic. Your corneal sensations would be decreased, and you could have periocular vesicular skin lesions, as beautifully shown by Professor Lal Raj. Then keratitis sicca or dry eye can present with, again, this coarse epitheliopathy. Usually it will be bilateral. Your Schirmers would be low and you would have a short breakup time. Acanthamoeba keratoconjunctivitis may be associated with pain or may not, and around 30% of the cases would have radial keratoneuritis, but sometimes it may be difficult to differentiate. Thigson's superficial punctate keratitis also comes in the differential diagnosis, as does exposure keratitis, where you could have lag of ophthalmos, eyelid deformities, and this SPKs in the inferior two-thirds of the cornea. So before we go on to how to treat these cases, it's important to know what microsporidia are. So they are, I would say, not uncommon causes of keratoconjunctivitis, and the keratoconjunctivitis caused is usually unilateral. Now, these organisms were earlier considered as intracellular spore-forming protozoan parasites, but now for many years have been reclassified as fungi, mainly because of the presence of chitin in the walls. And spores are the infective form of this organism, and because of this thick outer wall, they are highly resistant to the adverse environmental conditions, and they survive ubiquitously in all environments, in water, soil, and on surfaces. The initial reports all suggested that keratoconjunctivitis by microsporidia was caused in immune-compromised patients, mainly HIV patients and other immune-compromised patients, whereas a deep stromal keratitis was often seen in immune-competent individuals. But in the last decade, we've had multiple reports where we've seen that the microsporidial keratoconjunctivitis does occur in healthy immune-competent adults as well. There are definitely certain risk factors which would increase the propensity for a patient to develop these. That would be an immune compromised state, topical steroid use, which itself is a local immune compromised state, soil exposure, water contamination, and minor trauma. We had published a small series in Beijing in 2017 where the main focus was on the confocal microscopy findings, but we saw that most of these patients did have some history of risk exposure. However, another large series from the south, this was a study of 550 gram stain positive microsporidial keratoconjunctivitis patients. And there are some points that I would like to highlight which were important in this study. So bilateral involvement was seen in 5% of the patients. This is not common with microsporidial keratoconjunctivitis, but we need to be aware that bilateral cases can occur. And this was also very recently published just in the recent issue of 1 or 2 months ago of Cornea, where they have reported 6 cases of bilateral microsporidial keratoconjunctivitis. And it was shown that bilateral cases tend to have a more recalcitrant and a prolonged course. The other thing which was shown in this study by Rashi et al. Was that there was no predisposing risk factor in the majority of the patients. So this is just to highlight that we need to be aware that some of the patients may not remember having been exposed to a risk factor, and that should not rule out this diagnosis. And around 10% of the patients could go on to develop subepithelial nummular keratitis, where then one could confuse it again with the later stages of adenoviral keratitis, where we see the subepithelial infiltrates. This has been my personal experience that occasionally a mild anterior uveitis may develop. Frankly, I have seen it just in one patient actually. So this was the first patient which I showed, the 35-year-old lady. After 1 week, she came back with a much better vision and she was much more comfortable. But she complained of a new onset pain of a different kind from what she was having previously. And while both clinically and on ASOCT, no creatic precipitates had been documented at the first visit, at 1 week, the corneal lesions had healed, but she had a few non-granulomatous KPs on the posterior surface of the cornea, which responded to an addition of a mild dose of steroids. So how do we reach a diagnosis of microsporidial keratoconjunctivitis? Since microsporidia are obligate intracellular parasites, hence cultures using the routine media are difficult to obtain, and only tissue cultures are required, which often the facility would not be available. Luckily for us, these smears from the corneal scrapings have a very high degree of sensitivity. And most of these smears we are using in routine microbiological workup. So Joseph et al. Showed that KOH wet mount with a calcofluor white had a nearly 97% sensitivity. A routinely used gram stain and Giemsa stain also have between 70 to 90%. And the modified Zeal-Nielsen stain is said to be almost pathognomic for the detection of microsporidia. So these are pictures from some of our patients. The picture on the top left shows the microsporidial spores, small ovoid bodies, seen beautifully in a KOH wet mount. And as you stain them also with a calcofluor white, you can see them either as isolated spores, depending on the density of on the load of the organism, or you could see them in clusters, grape-like clusters. Now, the differential diagnosis for these conditions could be a yeast, which, however, would often show budding, or acanthamoeba cysts, which, as seen on the picture on the right, are usually much larger and are double walled. So, we've seen in our experience that if we have these oval structures with a structural halo, these are often microsporidia. And this is the Zeal-Nielsen stain, which is showing the microsporidia. The ASOCT also shows the lesions to be limited to the corneal epithelium, and they appear as slightly raised hyperreflective dots, vis-a-vis in adenoviral conjunctivitis in the later stages, where you would see some degree of stromal involvement also. The other thing which I find very useful in practice also is the use of in vivo confocal microscopy if one has the facility for it. And we've shown that the microsporidia can be seen as these intracellular and extracellular bright ovoid bodies, which resemble the spores seen on the KOH and calcofluoride. Now, the resolution of the IVCM is 1 to 2 microns. And since most microsporidial spores are larger than this, we can pick them up on the confocal microscopy. And this is to differentiate them from the acanthamoeba cyst, which again is much larger and double-walled in the picture on the right, whereas the microsporidial spores are smaller. The other thing that we observed and has also been reported is that sometimes you can confuse in the initial stages also between adenoviral and microsporidia, because adenoviral in the initial stages would have this vesicular lesions on the cornea, which later usually clear up. And in adenoviral, it's been seen that there is an exuberant dendritic cell infiltration in the underlying stroma, whereas this was strangely missing in the microsporidia. So most important, how do we treat these patients? Now, it's been shown repeated times that microsporidia is a self-limiting disease, and there are no well-established guidelines for its treatment. So people have gone on from using medical treatment to treating just with topical lubricants as well as the surgical corneal epithelial debridement. For the medical also, there is no definite consensus. It's said to be responsive to topical fluoroquinolones. People have used fumagillin, then also PHMB and propamidine isothionate as used for acanthamoeba. Oral antifungals, antiparasitics, albendazole, and also 1% voriconazole. Why I have highlighted this in red is because there was this small case report of 2 patients actually, which was published in Archives of Ophthalmology in 2011, where voriconazole was shown to be effective. And that, in my experience, I would like to hear the response of the other panelists to that also, works extremely well. And I am using voriconazole for all patients. Surgically, a lot of people prefer doing just corneal epithelial debridement to doing the reducing the load. I personally am not in favor of it because I think it causes the patient a lot of discomfort, and also there is the chances of secondary infection. There was also this paper in IGO where they studied 120 patients, and they showed that debridement does not have a significant advantage in terms of the resolution of corneal lesions. But I'm sure there are a lot of patients who do, people who just do debridement and treat the patient with lubricants. A last word on microsporidial stromal keratitis. Now, this is a completely different ballgame from keratoconjunctivitis. Why? Because one, the keratitis has a non-specific clinical picture, and there are no characteristic features which have been defined for microsporidial keratitis. It is very frequently, in almost half the cases, misdiagnosed and hence initially inappropriately treated as HSV keratitis and fungal keratitis. Consequently, it's been shown that most of these cases have a prolonged course with a smoldering keratitis and refractory to conventional medical therapy. And corneal scrapings are positive only in half the cases, and half the cases may have deep infiltrates which are not amenable to scraping also. And around three-fourths of these patients, it's been shown in this series, needed surgical management, partly for the reason that since they were not responsive to treatment, and secondly, because the diagnosis could be made only after the histopathological examination. So to conclude, microsporidial keratoconjunctivitis should be suspected in cases of unilateral follicular keratoconjunctivitis, especially those presenting with a coarse elevated corneal epitheliopathy. Bilateral cases, though uncommon, are also reported. The KOH and calcofluoride stain can provide a rapid and reliable diagnosis. Gram and GIMSA are also routinely used and also have a high sensitivity. Confocal microscopy is often a valuable pre-laboratory diagnostic tool, and I am very partial to using it. Many cases may present without obvious risk factors, and we should be aware of that. Treatment approaches vary from just lubricants and conservative to surgical debridement. My personal preference is topical voriconazole plus minus fluoroquinolones if we've debrided a lot of the epithelium. Thank you.
Thank you. Thank you, Dr. Chintan. It was a very nice presentation on a topic about which there is a little bit of controversy as far as management is concerned. And I will just say, okay, Dr. Nanda wants to leave.
No, I would have some comment and then go.
Okay. You would like to say something? Sir,
Yes.
please go ahead. There's one question for you also, sir. There's a question from Dr. Pushpa Gaikwad that how do we use povidone iodine before cataract surgery? So that if you can just.
Yeah, I'll answer that first. Povidone iodine is to be used preferably at least once or 3 times in a span of about half an hour before the surgery. What I prefer to do is a 5% povidone iodine eye drop, which I put after the antibiotic drop is over. So my first 3 antibiotic drops are put the first 30 minutes pre-op, and then the last 30 minutes of pre-op time is povidone iodine along with the mediatic drop, and the last drop is just before the patient is draped. So this is how. And of course, povidone iodine 10% is to be applied locally and allowed to dry and kept for at least about 10 minutes before the patient is shifted to the operation theater. And a second application of 10% povidone iodine solution should be done over the periorbital area on the table. So there should be 2 applications of povidone iodine 10% on the periorbital area, and 2 to 3 times application of 5% povidone iodine inside the eye. The last one just before the patient is draped. There are people who also take a swab with povidone iodine and clean the lashes before the drape also on the table. Now, coming to Dr. Chintan, it was a nice presentation. I'll just briefly explain about our experiences. In fact, my experience in this part of the Eastern India, where we have a lot of patients coming to us in the month of August, September, October. This is the rainy season in Eastern part, where the incidence of microsporidial keratitis is very high. We normally give lubricating drop with a prophylactic antibiotic 4 times a day for about 7 days, and invariably, the two types you said, one is the peripheral lesions and central lesions. The peripheral lesions heal up faster. The central lesions, they become more diffuse in the sense the typical gluten appearance goes, the patient becomes more symptomatic visually. The clinical picture looks better. The cornea appears more shiny. The glued-on appearance of SPKs are gone. They become more diffuse, and the patient becomes more symptomatic regarding vision. They are not complaining about the vision when they come first, but after 7 days, though you see the cornea to be better, the visual symptoms are more. So second point is, as you said, the incidence of developing some form of uveitis is probably much more. It must be more than 30 to 40% of our patients here who develop fine KPs, who come with fine KPs on the endothelium. So that probably prompts me, I would say, to give some sort of a low dose steroid after 7 days to clear up that. And the third point is about the IOP. I would again say about 25% of my patients do have inflammatory rays IOP here. These are my comments which I find, and I have not used any case with voriconazole, as you said. Probably that would.
That is a controversial point. I agree, sir, because I think most
We
people.
welcome Dr. Bhupesh Bagga also. He has joined us. And
Chintan ma'am, similar to your experience, we use fluconazole.
Yes, that was in that publication also. Yes.
Yeah. So that works good.
Because
And
what I've seen, my experience
what's
has been that once patients come to us, they have already been on fluoroquinolones. Usually they'll have shown somewhere outside, they'll be on fluoroquinolones for 1 week. They are not symptomatically better at all. And sometimes I've tried giving just lubricants, but the course is much more prolonged. But the moment you add on this voriconazole, within a week, usually they will all be very asymptomatic and very, very comfortable. That's been uveitis. I have seen very less, but yes, in a couple of patients. But yes, that's a learning point that you see it so frequently.
Have you seen
well, of course,
numerous
this
lesions, ma'am, post microsporidial?
Sorry?
Numerous lesions post.
I have seen them mostly in patients who have been pre-exposed to steroids. If they are treated primarily, then I have seen very few actually.
And I would like to have opinion of the panel regarding debridement. What is your experience on debridement?
No.
I generally never did, and I just agree with Dr. Chintan. Most often it is voriconazole or fluoroquinolones. They work very well, and I really appreciate, because it's a large case series in a series, so we'll have to accept that voriconazole would work. A large case series of microsporidial keratitis, and it would work. But I had not done a debridement. Meantime, sir, regarding povidone iodine, it is more than the frequency of application. It is the contact time of iodine.
Yeah.
If the contact time is more than 30 seconds, if it is 1 minute or more, then the killing effect is more. If it is less than 30 seconds, less than 15 seconds, then it doesn't kill.
Yeah, actually, there's a study which has compared 5% versus 1% also inside the eye, and they have shown that the 1% also gives similar results. But in the conclusion, they finally concluded that we would still stick to the 5% thing.
5%.
So we all do 5%, I guess. And there is a study which has shown double application of double preparation by povidone iodine significantly reduces the organism. So double preparation means one 10 minutes before and then another one once the drape is being put, drape has been put. So people have done double application, and of course cleaning of lashes, etc. should be definitely be done. That is a part of a routine hygiene. So let's move on, and we move on to the next speaker, and that is Dr. Madhu, who will be talking to us about fungal keratitis.
Thank you, sir. Is the screen visible, sir? Can I go ahead?
Yes.
So firstly, let me thank Namrata Sharma ma'am and Rajesh Sinha sir and AIOS for giving me this opportunity to be speaking along with Star Worlds in this field. It's a great honor. So in the next few minutes, I'll be speaking about fungal keratitis. So I come from one of the rice bowls of India, that is the Godavari Delta. So you get to see a lot of lush green fields that you see in this picture. But along with this lush green fields, you also have the fungus that is lurking here, waiting for an opportunity of a trivial trauma to infect our corneas. So I have no financial disclosures. So I'll cover the topic under the following headings. So fungal keratitis is far more common in our area when you compare to other form of keratitis, and it's also very severe. And the perforation rate is also 5 times more when you compare it with bacterial keratitis. And the need for therapeutic graft also varies from 20 to 40% of the cases, making it one of the largest contributors to therapeutic grafts. And outcomes when you compare with other cases also are poorer, especially if the fungals are larger in size. And the burden of fungal keratitis is also more. It costs 3 times more than what you treat to a bacterial keratitis for the patients. And given the background, we also see around 3 to 4 new cases daily in our routine OPD. And the most common risk factors that we come across are trauma with vegetative matter, as I've already elaborated, especially in agricultural population. Adding to this, the over-the-counter steroids play a very important role in development of these steroids, in these keratitis. And most commonly, the post-op steroid that we give for cataract are there in these homes already. And whenever there is slight redness, they tend to use the steroids drop that are already there in their homes. And we see more cases, especially in the season of reaping of paddy, when the trauma can be more. And in fusarium, we see more commonly in South India. Aspergillus, you see more commonly in the north and eastern part of the country. Candida, we see very rarely, and whenever we see, it's usually in immunocompromised patients. So fungal keratitis, these are the early clinical signs of fungal keratitis. You can easily mistake it for a dendrite, and you have to differentiate it from a dendrite and treat it accordingly. And also as it progresses, you can also mistake it like a geographic ulcer. So the best way to differentiate is to do a corneal scraping and see. A simple KOH wet mount will show you these filaments. And in either case, by doing a therapeutic debridement, you're doing a benefit to the patient, so we need not worry about that. And next, you have the classical fungal keratitis, which is described with feathery margins, hypopyon, satellite lesions, and aspergillus. So in the fungal keratitis, clinically, you can see the fungus attacking probably in 3 layers. If it is more superficial and it is spread only over the anterior stroma or sometimes even on the epithelium, it is usually because of demeticious fungi. It's like a carpet-like spread. And when you can lift one of the edge, it will come out like a carpet. And unless you do that, it will not go away. Then you have fusarium, which is usually restricted to the anterior or mid-stromal level, and it responds well. Aspergillus, in our experience, is more difficult, and it tends to penetrate more deeper, and it has more endoexudates. Larger hypopyons are associated with aspergillus. And this is the advanced case where you have endothelial plaques, limbal involvement, and perforation. Most commonly, we can misdiagnose fungal keratitis with pythium keratitis, which is very similar in presentation, but there are 2 hallmark lesions that will help us differentiate it from fungal keratitis. One is this tentacular projections that you can see here, and other thing is the peripheral gutter like a PUK that you can appreciate in the other pictures. So you are treating a case of fungal keratitis and it's not healing with the maximum medical therapy, then you should have high suspicion towards pythium keratitis and look for these 2 differentiating factors of tentacular projections and a peripheral gutter that will help us differentiate between these 2 identities. Coming to the microbiological evaluation, KOH is the simplest test that we can do that's very sensitive. Then you have grams where you can easily see this beautiful filaments. And this is the growth on potato dextrose agar. And this is the fungal filaments that you see on in vivo confocal microscopy. So in vivo confocal microscopy has a role, especially when the ulcers are not scrapable and the ulcer is inaccessible to scraping. Like here, if you can see in this picture, where the cornea is almost clear, but the ulcer is extending from the inner lip of the tunnel. And if you can see here on in vivo confocal microscopy, the depth is also on the AC. It's almost 834 microns, and you can see this beautiful fungal filaments that are demonstrated by in vivo confocal microscopy. To go a step further, in vivo confocal microscopy, you can broadly identify the species also. So usually Fusarium have branching at 90 degrees that are shown in the microbiological picture. So most of them will be actually branching, and from that branch again, you'll not see further branches. That is how Fusarium usually presents in vivo confocal microscopy. Whereas Aspergillus usually branches at 45 degrees and there is dichotomous branching. And from that dichotomous branching, again, you have more branching at 45 degrees. So broadly, Fusarium will branch around 90 degrees. It will not have this dichotomy, whereas Aspergillus tends to be dichotomous with 45 degrees angle in the limited experience that we have seen. So coming to the fungal keratitis treatment, we have adopted the TST protocol from AIMS, from Namrata Sharma madam's group, that is topical therapy, systemic therapy, and targeted therapy. So first we give for all filamentous fungi natamycin 5% 1 hourly. We add voriconazole in case of deep ulcers or non-responding ulcers. But the important take-home message here is never give voriconazole as a monotherapy. That is the results we got from the MUT study, because in the voriconazole group with monotherapy, the perforation rate was higher. And in the same way, itraconazole eye ointment we prefer for nighttime application. Symptomatically, we treat with atropine analgesics and anti-glaucoma medication. We have recently presented a paper at the Academy where we found the efficacious role of doxycycline, oral doxycycline 100 mg for its anti-MMP activity. And therapeutic debridement also, we do it every 3 to 4 days as the patient comes for follow-up. And systemic ketoconazole, we give it as per the TST protocol if it's not healing to topical therapy. And if it is candida, we prefer amphotericin B. Intracamal and intrastromal, we don't have much experience, but experience with the Namrata Sharma madam's group and Dr. Rishi Swaroop, I think they use it more routinely and they have good outcomes. We prefer to go in for an early TPK. And definitely there is no role for cross-linking in case of fungal keratitis. I was one of the investigators for the first randomized control trial, where we found out that cross-linking has no role in fungal keratitis, especially deeper fungal keratitis. The perforation rate was higher in the study group when compared to the control. So, and the CLARE trial also confirms that there is no role of cross-linking for fungal keratitis. However, one interesting development in this area is the role of tacrolimus for its anti-inflammatory properties. There are studies that show its beneficial role in the animal models. So despite the maximal medical therapy, almost in 2 weeks, 75% of these cases heal. The reason why they heal is when you give specific therapy instead of empirical therapy that's done by most of the general practitioners, the specific therapy helps for better drug compliance, and you're not killing the commensal bacteria that are there in the eye, which usually have a beneficial role in the healing process, then they act against the fungus. Because of these two factors, when you give this kind of specific topical therapy or systemic therapy, the ulcers heal better when compared to an empirical therapy. So let us see the intrastromal injection video that I have for you. So this is a case of fungal abscess that you can see in the graft-host junction. So here we are trying to drain the abscess that is there. So whenever you give an intrastromal injection, if you know that it's an abscess for sure, it's better to drain the abscess and then try to give an intrastromal injection, because that will be more efficacious. So here we are trying to read, but because of the thick nature, we are not able to get it out of the needle. So then we have removed the needle, and with help of a hypodermal syringe, we could drain that flap. And now we can hydrate the area of the ulceration with help of a intrastromal voriconazole. It hydrates as you hydrate your side ports in the cataract surgery. So with intrastromal injections, most of the times it may not suffice with a single injection. You may need to give multiple injections, and that is one thing you have to remember. So let us see the case of a therapeutic keratoplasty in case of a total corneal ulcer. So ulcers like this, you can't do any trephination. You have to do a freehand dissection, and you have to put the whole thing. So this is almost a total ulcer where the limbus is also involved. I like the point where Rajesh Sinha sir told that we can give intrastromal or intrascleral injections in cases like this to prevent any reinfection. So that is the endothelial plaque that is adherent to the iris. You have to make sure that you clean all those things. You have to lift the iris and clean the infiltrates that are there beneath it. Next, you place the graft as a whole and then suture it probably with 9-0, especially if the sclera is involved. And these cases will invariably develop glaucoma and probably will require a drainage device in the long term. So thank you for the opportunity. I thank my teachers, Dr. M.S. sir and Prajna sir, who are known to have contributed a lot to the literature in fungal keratitis. Thank you.
Thank you, Dr. Madhu. It was a very nice presentation, very well covered, and some of the things that you showed were really very, very interesting. The way you drained the, the abscess and all those, it was really very good. And of course, the therapeutic graft, which was required, it was a very large size graft. I guess maybe it was a 12 millimeter, 13 millimeter.
Yes, sir. Total, sir. We just put the tissue as it is.
Yeah. So such scenarios, are really difficult scenarios because, I mean, a good surgeon like you can do a good surgery, but what is even more required is the post-operative care in these patients. And we really have to be very vigilant.
Yes.
Any comment from any of the panel on that?
Most often, yes. Most often in land like ours, natamycin, because filamentous fungus are the main pathogens. So most often it is natamycin which has the greater role than imidazoles. Imidazoles, as he rightly mentioned, cannot be given as a monotherapy unless and otherwise it is pus forming or abscess forming fungus like candida. Otherwise, it is natamycin that plays a vital role. And surgical debridement, scraping, therapeutic scraping, removing all the slough, that is very much important also. So,
very well pointed out. Actually, debridement is something which I keep telling our residents also, our fellows, that debridement is something which is very essential in cases of fungal keratitis for two reasons. One is, of course, the infiltrates are quite dense and you have to remove that. Otherwise, drug will not penetrate. And secondly, the drugs themselves, they have poor penetration. So in order to improve as well, we need to have debridement.
What is the experience of the panel with caspofungin? I would like to.
Yes, it's something which is really, very... I have a couple of case reports wherein, I have used caspofungin. And one is a medical student from Jodhpur, I think. And actually, what I felt that the results in both the cases are very good. And the scarring was also much less than what we normally notice with natamycin or voriconazole, etc. So I was quite impressed, and I'm actually planning a comparative study on that.
What would be the ideal case in which you would go ahead with?
Well, it's very difficult to say that what would be the ideal case, but yes, of course, a proven fungal keratitis wherein you can start casofungin. I actually, in this case, he was a medical student and he already had taken netamycin from his medical college, and there was a proven fungal keratitis. So I just changed to, I just thought that let me do something out of the box because natamycin is not working. Either there were two options. Either I would have added voriconazole to that because it was a proven fungal, or I would have done something. I changed to casofungin and it worked well. Another case after that, I used casofungin, and both the cases, the scarring was much less than, than, but in just two cases, I cannot be, I am not in a position to make a definite comment, but I have two good reports, cases with good results. So
what is the dosage, route of administration, and for
topical.
Okay.
Yeah.
You prepared it, Dr.
But-
Christina?
Sorry?
You prepared it in your lab, or you from
In our
where
lab,
you-
yes.
Yeah, that's not commercially available.
You have to
You,
reconstitute.
you do actually you do get injection of casofungin. Yes, it is available.
And no, it's not commercially available as a topical agent.
No, not commercially available as a
Yeah.
topical agent. So you just have
We
to
need to
reconstitute. You have to
Reconstitute.
make it 0.5%, and I mean, in both it worked very well. So I'm planning a study and already given to one of my candidates. So let's see, and let's hope how things work out. So I think we should not, have Dr. Bhupesh Bagga waiting, and let's have his presentation on acanthamoeba keratitis, and which is fortunately, I do present on, when I present on acanthamoeba keratitis, I say that fortunately it is less commonly seen, but if it occurs, then many times it can have very severe outcome because it requires a long-term therapy and so many issues. So let's have Dr. Bagga's opinion on that.
So thanks, Dr. Namrata Sharma and Dr. Rajesh Sinha for this opportunity. Able to see my slides?
Yes.
So as you said that this is fortunately less common, I also call it as a ring of fire, and this is really a devastating infection when it happens, and if it diagnosed early, it can be managed, but if it really late presentation as usual, it's very difficult to manage it. So I will show some basic slides and then go to case presentations. So we call it as a ring of fire because we see almost 60%, 55 to 60% cases presenting as a ring of infiltrate, stromal ring. So acanthamoeba is basically a free-living protozoan of subphyla Sarcodina. The two important species which are important for ocular and corneal point of view are Acanthamoeba castellani and Polyphagia. But the most important thing is why this organism is really challenging to manage is the cyst stage along with trophozoite stage. Trophozoite are manageable, but when they got they got under encystment, actually it's very difficult to manage that. And that is why this infection is having its own challenges, that chances of recurrence and late treatment and late response. It is the most common cause in Western countries is contact lens user. We are also seeing a lot of cases now which are induced by contact lens use because of increasing use of contact lens in our country also. But otherwise, trauma is supposed to be most important cause in our countries. Coming to presentation, it can vary from early to late presentation. From early, like epitheliopathy, you see pseudodendrite or a small epithelial defect along with a little bit of cellularity along this epithelial defect, or you can see like a perineural infiltration along with diffuse infiltrate of a pinhead type of lesions. But very importantly, you start seeing limbitis in these early limbitis in these patients. So if a patient is having unusual pain with epithelial defect along with cellularity, with diffuse fine stromal cellularity along with limbitis, definitely you should start thinking in line of acanthamoeba also should not just give steroids and wait for 3 days and 5 days, because at that time they usually present like an early ring or early diffuse stromal infiltrate. So that is the early disease which if you are very lucky and very curious to pick up, you can pick up. But most commonly it presents in the form of ring, that is very easy to diagnose, and you are basically first differential comes in your mind when the history is around 30 days or 15 to 20 days and presentation as a ring and stromal infiltration. Start thinking in line of ring infiltrate, and most common differential comes in line of acanthamoeba. But it can present as a diffuse infiltrate, as a scleral nodule, as a multilocular infiltration. So the variation in the presentation is basically to depends upon so many things, and most important thing is the use of steroids as well as use of other drugs and presentation, and also the causative factor. Contact lens induced cases are much more milder and much more earlier presenting as a fine infiltration versus trauma induced. So most commonly it mimics as a viral keratitis, and that's why it starts. Usually patients are using HSV keratitis. Usually presentation are using antivirals or steroids. But second most common infection is the fungus. Like this patient presenting as a ring infiltrate and is being managed as acanthamoeba on presumptive treatment, but on scraping it was uh, came out to be a fungus. So again, very important thing to rule out all other organisms and do a proper microbiological workup before starting treatment for acanthamoeba or treatment for fungus. So this patient, like a fluffy infiltrate having hyphae extensions, came out to be acanthamoeba. This is like an early ring you are seeing and started seeing a stromal diffuseness, but the pinpoint is you started seeing if multiple pigmented KPs, then again just think about more of acanthamoeba rather than virus. So this patient was having a trace hypopyon along with diffuse stromal infiltration along with multiple pigmented KPs. It came out to be acanthamoeba being treated as virus. This diagnosis is not that much difficult if you can scrape it and do under microbiological examination proper gram stain and KOH with chalcopyrrolite is it demonstrated as a double walled ring, and also can be picked up on confocal as double walled cyst. Otherwise, its growth under non-nutrient agar media with enriched with E. coli is one of the confirmatory way to confirm it. It's usually seen under a microscope, as you can see a pinpoint, or you can see dot lesions are there, which can be a little better when seen under magnification. So coming to one more spectrum of the disease, when this is presenting like a diffuse infiltration and a presentation as a diffuse ring infiltrate with hypopyon, and can be definitely you can say confused with fungus keratitis or bacterial keratitis, but on scraping it came out to be a acanthamoeba keratitis. So I will present two entities here. One is when patient is presenting like a complete no treatment with use of steroids, history of 1 month, and presenting as acanthamoeba, versus patient who have been managed for long standing with acanthamoeba. On histopathology of this patient, you can see a plenty of acanthamoeba cysts are available are there, but where the infiltrations are there, you're not able to see any cyst. So this is basically on histopathology on PAS and GMS, and on the staining of histopathology you seen that you are seeing plenty of cyst without much of inflammation in the center of the cornea, versus plenty of infiltration of inflammatory cells with very minimal cyst. So at the ledge of guttering, you will see more of infiltration with the neutrophils and along with the inflammatory cells, versus cyst will be mostly in the center, which are basically plenty of cyst here with minimal inflammation. If you see this patient who presented as a ring infiltrate and managed almost 6 to 8 months with anti-acanthamoeba medication, develop mature cataract, which is also very commonly seen in patients who have been managed on long-standing treatment with acanthamoeba medications along with the other medications. So this patient actually got resolution of an acanthamoeba infection on steroids as well as on PHMB and chloroquine combination. But on on confocal, you could see again some cysts were still there. So clinically, there was no infiltration, only mild, you can say circumcorneal congestion is there, and plenty of bullae are there. On histopathology, you can see the minimal inflammation with some cysts are there, which are not, which are very, very different as compared to the acute tumors. If you compare between these two cases, having a very round, well-defined cyst versus ill-defined cyst and empty cyst in this. So we call it as a chronic acanthamoeba stomal keratitis versus active stomal keratitis. So it's the poor prognostic factors, which are basically you can predict your patient how it will behave. If it is presenting as a deep stromal or as a ring infiltrate, or patient had used steroids more than 1 month. Duration of P-diagnosis, if it is around 2 weeks or less than 2 weeks, along with the post-diagnosis if you're still using steroids. So these are the four reasons to prognosticate as a poor prognostic factor in cases of acanthamoeba keratitis. So I usually prognosticate in this form and start giving them mild, moderate, severe criteria based upon the prognosis and to plan surgery or not to plan surgery according to these predictors. So coming to medical management, biguanides is the mainstay of treatment where we combine, usually give chlorhexidine or PHMB. Many a time patient has been given monotherapy of chlorhexidine and PHMB, but we advocate a combination of both chlorhexidine and PHMB in all cases of our acanthamoeba keratitis patients. Diamides are also one of the way to treat it. Azoles are one, other treatments are there which have been tried in acanthamoeba keratitis, as well as alkyl phosphocholeins, which are the newer treatment which is recently approved as an oral treatment for acanthamoeba keratitis. Medical management in terms of monotherapy versus combination therapy. So people use both. We use combination, but as per different papers, the actually PHMB chlorhexidine combination is almost equal in efficacy versus monotherapy. But in our experience, it is basically have a synergistic role of PHMB and chlorhexidine. So we usually combine both the medications. But usually the permeability of these both medications are very poor, and that is the reason that deeper infiltration of the acanthamoeba actually are very difficult to manage versus superficial. If you see use of steroids, if the patient has been given steroids, the number of trophocytes are very, very increased. So they're very difficult to manage those cases if you are not managing with acanthamoeba medications and giving only steroids, and those cases actually having worse prognosis. So usually we indicate use of steroids if patient is already have been used of more than 2 to 3 weeks of acanthamoeba treatment, also having persistent inflammation or very severe pain or anterior scleritis. So these are the few indications where you can advocate a use of steroid, but very, very carefully observation on and very close follow-up of those cases. So corticosteroid therapy is not commenced until 2 to 3 weeks of biguanide treatment has been completed. Continue corticosteroid therapy until good control of inflammation is achieved. This I'm talking about when your patient is having complete resolution of acanthamoeba keratitis and you have managed successfully those cases. You can continue acanthamoeba medications after stoppage of corticosteroid therapy. When the eye has been free of inflammation for 4 weeks or while using a biguanide alone, the condition is labeled as cured or all therapies are discontinued. So basically 2 to 4 weeks after clinical resolution of acanthamoeba keratitis, we discontinue acanthamoeba medications and also use of steroids. So one other drug which is have been tried is efficacy of voriconazole. We have done RCT and we got recently published in Eye about cases where we treated 8 cases with voriconazole versus 10 cases with combination, and result is not you can't say that they are 100% this thing, but yes, there are some role of of voriconazole monotherapy. Although there are reports of voriconazole and chlorhexidine which are not working together, and in vitro actually they are inhibiting its own role. So you can't combine these two medications, but per se monotherapy in voriconazole versus in acanthamoeba keratitis has some role according to this study. So one more drug, as I was telling about, is the miltefosine, which has been recently, means around 3 years back, it got approved from FDA as an orphan drug category, and And there are certain papers which have been using for refractory acanthamoeba keratitis. So this is basically in continuation with biguanides. So like this patient has got used for PHMB chlorhexidine and got worsened, while adding of oral miltefosine that got complete resolution of acanthamoeba keratitis. There are other certain reports recently published by Elmer 2 group, around 16 cases they have managed in a combined some almost 2 years, and they have managed, and they say the role is quite beneficial in those cases which are not being managed successfully with the use of biguanides alone. So we have done an LVP use of topical miltefosine as based upon the 0.065% based upon the animal model. And those cases actually showed anterior stromal response, but posterior they were extending. So we concluded that topical topical miltefosine is not working in cases of acanthamoeba keratitis, but yes, it has its role in as a combination. So coming to few cases, like this lady presented as a contact lens wearer with on-off-on redness for 3 to 4 months and having use of steroids. So this patient was having androxydates along with hapopion. Basically, so all having characteristic of poor prognostic factors, but this got managed with the use of combination of biguanides. And when we are seeing a lot of vessels are coming and the size of infiltrate is decreasing along with scarring, we added steroids as well after 40 days of treatment, and this got complete resolution on patient is having now follow-up of more than 3 years. This patient had undergone LASIK and followed by LASIK, she developed post-LASIK ectasia and undergone collagen cross-linking. And as you can see, there's a classical ring infiltrate, and this was the flap of LASIK flap, where the underneath is the lash is also there, but already outside it was done flap lifting and revealed no organisms. But we did confocal, and we got confocal on confocal plenty of cyst, and we debrided also. On follow-up, she developed scleronodule, and we treated this patient with PHMB chlorhexidine 0.06% with increased strength of PHMB chlorhexidine. It got managed, complete resolution of the acanthamoeba keratitis. And later on, she developed corneal melting, undergone therapeutic PK, and later on she developed complete resolution and no recurrence of acanthamoeba. So this patient also undergone LASIK and developed interface LASIK acanthamoeba keratitis, which on follow with amputation of LASIK flap and with the continuation of PHMB chlorhexidine and timely administration of steroids, got complete resolution of acanthamoeba keratitis, which later developed complete mature cataract. And this is the latest follow-up where it completely resolved keratitis with good attainment of good visual acuity. So it is not always possible to achieve good medical treatment. We sometimes land up into melting of the cornea, and on follow-up, like this patient developed on melting and thinning. So this patient underwent DALK, and this is the final achievement of complete resolution with DALK. So we recently published some series of 30 cases where DALK has been performed and resolution is quite good. So we concluded that if timely and planned wise it was done, DLK is still having a good role in management of acanthamoeba keratitis. But this case was unfortunate where it was basically done for DLK and later on it developed recurrence, but it could be managed by complete metating keratoplasty. This is a newer treatment which we are trying of photodynamic antibacterial therapy with Rose Bengal, and this patient recently we managed. This is a girl of 12-year-old, and this got complete resolution in 1.5 months of acanthamoeba keratitis. This is not only one case, so we cannot say that this is working or not, but yes, this is the newer treatment. So on conclusion, I would say acanthamoeba can be missed, so keep a high index of suspicion, confirm microbiological diagnosis, treat with combination of biguanides or azoles, but don't mix it, wait for minimum 2 weeks to assess the response, use steroids very, very judiciously, and at least 2 to 3 weeks of anti-acanthamoeba medication. DLK has comparable results as our study shown as compared to PK with added benefits. I would definitely like to thank entire Javeri Microbiological Services and entire Cornea team of LV Prasad. Thank you very much.
Thank you, Dr. Rajesh. It was a wonderful presentation. Some of the very interesting studies that you have done. Uh, one you had showed that scleral nodule. Actually, sometimes what happens that these scleral nodules, they are immune mediated, and then you have to give steroids, and then it doesn't respond. Sometimes then you have to give immunosuppressives as well, like in one of my case wherein it was a post PRK canthamoeba keratitis, and then it was a proven one. And um, and as you also mentioned, that confocal works very well in some of these in diagnosing, getting an early diagnosis. So it worked in this case. This patient responded, but then she developed scleritis, and then it was a nodule was being formed, and we started her on mycophenolate. It responded, but then it was nodule was forming adjacent to the area which was responding. So overall she developed fleeting kind of one nodule getting resolving, and again another nodule forming adjacent to it, and then we had a 360-degree thinning later, but then subsequently it responded, and finally we had to go for a therapeutic graft in that also. So, I can't tell you, but sometimes it takes such a long duration, and you have to keep treating that. Many times things go wrong, and you have to resort to therapeutic grafts. Or, one thing what I felt that maybe an early DALC that you was mentioning, maybe that's an option in many of these cases. Another point that I would like to mention is that the propamidine is not freely available. That is one issue. But in Delhi, we do get propamidine. We do get it many times. It's not that freely available, but in one or two counters, one or two shops, it's available. So a combination of chlorhexidine or PHMB plus propamidine has worked well at our place. But many times we don't get propamidine. That's also an issue. So
In areas like us, it's bigonides and
just
azoles. Yeah.
unshare, Rupesh, can you just unshare the slides?
And meantime, Dr. Bhupesh, how do you manage pain?
Yes, that is again a very
Yeah.
Yeah.
interesting thing.
So pain management is, you're asking pain only.
Yes.
Yeah.
Yeah, it's very difficult many times in these group of patients, and if we have treated these patients with the more than 2 to 3 weeks of anti-conceivable medications, and they are still having pain, some use of oral steroids I prefer to use in those cases. Limbitis, because those patients are usually having severe limbitis, so starting of oral steroids, uh, and then they do very well when they use of steroids. And patients, as Dr. Sinha is mentioning, that limbal nodules, so those patients are usually immune mediated, but like this patient got while steroid deroofing, we got acanthamoeba cyst in those steroid nodules. And so usually there are signs like they are very yellow and they are having pinpoint pus lesions. We tend to think they are actually having infected nodule, versus if they are like more of less yellow and having no pus points and more diffuse, they are mostly of immune mediated, and those cases respond very well to use of steroids as
Steroids.
well as immunosuppression. So those are having pain, then IV methylprednisolone actually also having been tried, and we have given a good number of patients IV methylprednisolone. Actually those patients do well, and their pain and the symptoms actually do very well. And the interesting thing is when you're doing transplantations, so where you need not to take that much large lesions, when you do transplantations and use of steroids, in those cases, actually those nodule disappears quite efficiently. And you start thinking that, okay, this patient is having limbitis and develop limbal stem cell deficiency and so on. But though they do very well if you do transplant and use of corticosteroids early to manage that. So pain, actually corticosteroids is one of the mainstay in these cases.
Just to add to the pain management, a couple of patients, they teach you a lot, and I had a couple of patients wherein they responded, they were not responding to all these and even to the analgesics that we were giving. So I had to give opioids in those patients to reduce pain. And in two patients, I have used even patch. I had to take opinion from the anesthesia pain management team, and they suggested amitriptyline patch in those patients. And then I had to do that, put a patch of amitriptyline, and that worked in those patients, and she was very happy after that. So, these are, you get a spectrum of such cases wherein majority will respond to all these measures, but a couple of patients they teach you something, teach you that you have to do something out of the box, and this amitriptyline patch, and then in some cases tramadol, etc. They in a few cases you have to resort to these.
I agree with you, sir, because a few years back I had a case and she ultimately had to go with
Hello,
antidepressants, tricyclic
ma'am, you
antidepressants.
can
Yeah,
join. We are
antidepressants
just
are
closing.
required,
Mm.
and they
Almost
need a lot
completed.
of
Last.
psychological
बस
counseling also. That
thank you भी बोलना है.
I usually my acanthamoeba patients or patients who are long standing actually,
बस होएगा
they
complete.
need that type of counseling as well. And because they are you need see the signs are very less other than their symptoms, and you need to refer to definitely a psychologist to manage the pain. So that is also one of the way to manage these ulcers.
That's what happened in that case. She had to get antidepressants, and for the viewer's sake, a bacterial keratitis, when there is complete reepithelialization, that is sufficient enough. When the cornea is completely reepithelialized and there is no more sign of active disease, we may stop antibacterials. For a fungus, definitely even after resolution, for at least for a period of 2 weeks, we need to continue antifungals. And for acanthamoeba, it is at least a month or more, right?
Yeah, no,
Complete
no, I
resolution.
can't remember. You have to continue for almost 4 to 5 months after this thing, because
Resolution, complete
many
resolution.
times you do have some cysts which are still
Recurrences,
present there. So it
dormant
takes,
cyst will recur.
yeah.
Bhupesh,
There's one question for you, Lionel, that
Yes.
is your preference for prophylaxis, whether acyclovir or valaciclovir? What is your
Sir, I go ahead with the acyclovir most
acyclovir?
often.
Yeah,
That is freely available also in many places,
yeah. We also
especially
go
sitting in a
with
periphery.
acyclovir only. We also stick to that. There's one question from Dr. Madhu, and that is, what is the role of fluconazole in candida infection?
for Candida, usually amphotericin B works better, sir, in our experience. We can definitely add fluconazole or voriconazole also, but amphotericin B, the results are better, sir. Sir, I have one question for Bhupesh, sir.
Yeah.
Sir, we know that acanthamoeba is a very tenacious disease. So when do you take the call for surgery, sir? A surgical intervention, what is your threshold?
So if size is and posterior stromal involvement is there, and if you have treated the patient for more than 1 month,
1 month, okay.
then I would think in line of that, okay, this patient would definitely need surgical intervention, because usually the response starts in 2 weeks.
2 weeks, okay.
What is your experience with mixed infections in acanthamoeba? So, because literature sometimes shows that there are a lot of around 20 to 30% cases could have mixed infection, fungal or associated.
So we do have the recently published from our center, the acanthamoeba mixed infection versus plain acanthamoeba. So those patients actually are having a little worse, prognosis. But if you pick up that you have seen with fungus, we have seen with HSV, definitely we have seen. And recently I have seen one cases with pythium with acanthamoeba. So those cases are actually very difficult to manage. But fortunately, one thing is that if you are able to pick up it early, that acanthamoeba take a lead in all these cases. So they actually present as a ring, and on scraping, you start seeing some filaments, and if a curious microbiologist only can pick up those
Yeah.
broken filaments, and then you start what to do. So those cases actually, I would recommend, if not being managed, do plan early surgery rather than waiting for
Yes.
complicating the things.
Thank you.
And any specific signs that you look for to start steroids, sir?
First of all, if like if early presentation, patient is coming as early presentation as around anterior to mid-stromal infiltrate, and you are starting anti-cancer medicine, 2 to 3 weeks you observe the patient and you start seeing that infiltrate is not worsening, and you start seeing the rounding of those edges, and along with KP, those KPs are actually increasing beyond that infiltrate. Those white KPs are beyond the infiltrate, and that is the time when I add steroids. Number one. Number two is, if you have started having deep vessels from 360 degree, those are basically the one of the sign where you start thinking. Third, I told the size of infiltrate is not matching with the signs and symptoms. So more pain, limbitis is more, or presentation of limbal nodule. Those are the signs where you can start steroids, and do not hesitate to start steroids in those cases, because the hesitation creates a lot of confusion that your patient is worsening or not. Give steroids 4 to 6 times a day, and don't give lotiprevir, don't give FML type of thing. You give prednisolone acetate and give full dose, and see the response. Keep a close observation, observe the thinning, and start seeing the disappearance of KPs. You start seeing in 1 to 2 weeks, and then means that was inflammatory response. And that is very commonly seen in when you start the treatment, your patient actually start responding and then start worsening, and that is a sign of inflammatory response.
There was a general impression earlier that if there is an anterior segment, like anterior chamber inflammation, cells and flare, that probably it's viral. But in acanthamoeba, I have seen that, the inflammation matches with viral. So we have to think of use of steroid in these cases. Okay, so it was a wonderful discussion, a very good, presentation, complete package of, having everything in one session. So I thank you all. Thank all the speakers. Dr. Nanda is not here, but it was a wonderful presentation starting from him. And then, of course, Dr. Leonel Raj, Dr. Chintan, Dr. Madhu, and of course, Dr. Upesh Bagga. So thank you all. And I would also like to thank our AIOS team, Kirpal Rana, who is also logged in and is always there, very helpful in all our webinars. Sunil is our media person, the person who is handling this and of course Allergan, which is the company that has sponsored this webinar. So thank you all. Thank you, and of course we would like to have you again and again in our future webinars. Thank you very much.
Thank you, one and all.
Yeah, thank you, Dr. Rajesh. And because of you, I think I got the opportunity to hear Professor Leonel and Dr. Chintan Malhotra, because of we have never heard these two. I've discussed with Madhu many times, but I think thank you, sir, and thank you.
Thank you, sir.
Thank you, sir.
Thank you, one and all.